everyone. Good evening. This is Dr. Sullivan back with you for another I Care for Your Brain live. Tonight we are going to talk about Lewy body dementia. This is the most poorly understood subtype of dementia and the most misdiagnosed. So we need to talk about why is that happening, and we need to talk about what we can do better to make that not happen. If you've been with us before, you know that I have two missions in being with you weekly, which is to give you high quality education about the brain and empower you to advocate for better care for yourself or someone that you love, and to be able to have better access to a brain health expert that genuinely cares and can point you in the right direction for evidence-based recommendations. So what we are going to talk about tonight is Lewy body dementia, like I said. Now, this actually is a topic that is near and dear to my heart. I am very passionate about advocating for people living with all types of dementia, but I have found Lewy body dementia to be particularly interesting and compelling to me, so much so that when I was doing my board examinations, look at that hair, wild hair, to become a board certified neuropsychologist, I had to submit 2 case reports on 2 different types of patients to have experts quiz me on it and make sure that I knew my stuff. And so I submitted one on cerebellar stroke and the other one was on Lewy body dementia. So throughout that process of becoming board certified, I made sure I knew everything about Lewy body dementia so I could pass that test. So we think that about 20 to 30% of people actually have, on autopsy study, verified Lewy body dementia as their only form of dementia. But really how it gets into being the most poorly diagnosed is because it often is a secondary form of dementia, meaning that the person in life has mixed dementia, meaning they may have Alzheimer's disease as their primary form of dementia, but over time they actually develop another kind of dementia. And what typically happens is that once doctors think that they have it all figured out and we know that this is Alzheimer's, the truth of the matter is that further assessment does not often happen, and people simply get put into a category. And you know, this is a part of my whole platform, which is in devaluing and objectifying people with dementia. But for the purposes of our conversation today, I think that the truth is that the curiosity factor kind of goes away, and there's this feeling, I'm going to actually share some data with you later that supports this, there's this feeling of what's the added value of pursuing diagnostic clarity further because we think we have this all figured out. So there are a few reasons that Lewy body dementia has kind of fallen under the radar screen. So first of all, we just don't have a lot of access to experts in dementia. And this is a crisis because our population is slowly aging, right? The baby boomers are coming up. We have a lot of older adults that need geriatric specialty care, but we simply don't have enough physicians who are trained in geriatrics, or people don't have enough access to board certified neuropsychologists. And that is part of my motivation in doing these Facebook lectures, because I want you at the very least to be able to hear from someone like me once a week, to be able to have a reliable, objective, trustworthy source to get your information. The other thing is that there's a lot of overlap between Lewy body dementia and 2 other subtypes of dementia, which is Alzheimer's disease and Parkinson's disease with dementia. So we're going to talk tonight about how to separate all that stuff out as best we can. And then, like I said, the third reason are these stubborn negative beliefs about the value of accurately diagnosing people with dementia. So many times people are simply told this is dementia, and that's it. And a big thing that I try to go out in the world and do is to encourage and empower people to say, okay, that's a good start to this conversation, but I want to know what type of dementia this person has, because an accurate diagnosis truly means everything in dementia care, because that's your map of where to go in the future, right? That's how you know what treatments are going to work. That's how you know what to expect in the future. That's how you know how to make sense of the person's symptoms, not only for the person, but their care team, they're caregivers, and this is how we help people find the best fitting community resources. So to simply say something is dementia is very poor care in my mind, and frankly, I think it bumps up against unethical. I think it's very wrong. So let's talk a little bit more about Lewy body in particular. So think of it like kind of an umbrella term, and underneath this umbrella we have two different types of dementia. And they're both related to the presence of these protein clumps, these little kind of deposits that happen in the brain that are made up of something called alpha-synuclein. Now, depending on where they happen in the brain, this is going to determine if the person develops Lewy body dementia or Parkinson's disease with dementia. And those are the two disorders that are underneath our umbrella. So within Lewy body dementia, we break it down into two categories. The first one is probable Lewy body dementia, and the other one is possible Lewy body dementia. Now this is based on the verbiage is related to what is becoming more and more of an old stereotype that you can't diagnose subtypes of dementia until autopsy. Well, probably in about 90% of cases, well-trained neuropsychologists can in fact diagnose accurately what subtype of dementia is happening. Now this does get harder and harder the more advanced someone gets, and so one of the things that I say to patients about the importance of coming in early is that yes, in the beginning stages of all the subtypes of dementias, we have differences. There are things that are unique to Alzheimer's that you don't see in Lewy body dementia. But at a certain point, because all dementias are progressive, unfortunately, they all eventually lead to the same point, which is basically generalized dementia. Every single dementia ultimately leads people to the same point of confusion, difficulty managing their bodies, managing themselves. So sometimes if someone comes to see me too late, it is very hard for me to tell. I can do some kind of retroactive detective work and look at hospital records and these kind of things, but the truth is, when someone comes to see a neuropsychologist earlier, we actually do an excellent job of diagnosing subtypes of dementia. So within the world of probable Lewy body dementia, you have to have two out of these three symptoms. So let's go over them. The first one is fluctuating attention or waxing and waning mental status. And this is thought to be the cardinal symptom of Lewy body dementia. And this happens in about 50 to 75% of people. So let me explain to you exactly what that is. This is mental status that goes dramatically from one state to another. So typically, even within a 20-minute span, the person could have absolute mental clarity at say 12 o'clock, and at 12:15 they are almost in a trance. There's so much confusion, there's a lot of staring spells that can go along with this, that the person is disoriented, they're not even sure where they are, and this can happen up and down all day long. This is the big thing to look for if you are concerned that someone may have Lewy body dementia, because it's the #1 symptom. The other thing is that we have visual hallucinations, and there's some unique characteristics of these visual hallucinations that I want you to know. This happens in about 45 to 65% of people who go on to be diagnosed with Lewy body dementia. And the way we think about them is that these are what we call well-formed and recurrent visual hallucinations, and they typically take the form of little people or little animals that are around the house or in the yard, and they don't cause the person significant distress typically. Now this is different from psychiatric in a major mental illness like schizophrenia. In terms of those type of visual hallucinations, they're typically very distressing to the person, and they take all sorts of different forms. So with Lewy body, you typically hear people talking about a little dog that was running around, little children that are in the yard, a little rabbit that keeps coming by. And this is so common that there's actually a clinical term for this called Lilliputians, and it simply means little people, little things. We, of course, also have motor symptoms, and in about 25 to 50% of people, we have symptoms of what we think of as Parkinson's disease. And what we think is, I'm going to talk to you about this in a little bit, but the timeline of when Parkinson's symptoms start and when the dementia starts is absolutely critical. But let's talk about these suggestive symptoms. So I just said before, you have to have 2 of those 3: waxing and waning, fluctuating mental status, well-formed visual hallucinations, and the Parkinson's symptoms, okay? Then we have these suggestive symptoms, which many people have, but not everyone has, okay? So the first one that I think of is something called REM sleep disorder. And what this is when the person is in a deep sleep, in a state of REM sleep, they act out their dreams. They kick, they punch. When the brain is healthy, there are a lot of inhibitory controls that keep us from acting out our dreams in REM sleep. We're kind of paralyzed. In fact, a lot of us have those dreams where you're trying desperately to move, but you can't. When a part of your brainstem is not working well, in this case, because those little protein clusters are killing the neurons, the brain cells that live in there, this inhibitory process no longer works. And in fact, the research tells us that REM sleep disorder for many people is probably the very, very first symptom that happens even decades before the symptoms of cognitive and motor decline. Very interesting. So the next one is what we call autonomic symptoms. So this is trouble regulating blood pressure, falling unpredictably, having a hard time holding your urine. So this is a lot of the autonomic things that happen in the body that we're totally unaware of, that just when you're healthy, magically kind of happens. And so, for example, if someone gets up out of their chair too quickly with Lewy body, they can see those little black stars and they can actually lose their footing a little bit and fall over, because the blood pressure system, the regulation of it, the automatic nature of it is not working well. The other thing that we can have are things like repeat fainting, what we can call a syncope, which is just someone having difficulty maintaining their consciousness throughout the day. So there can be passing out symptoms. There are no brain imaging studies, no MRI, no CT can diagnose Lewy body dementia. There are no biomarkers. So what I mean by this is in other subtypes of dementia like Alzheimer's disease, we do sometimes do spinal taps on people because you can actually see some of the pathological markers in the cerebral spinal fluid. There are some protocols for research institutions that say you can sometimes see that in Lewy body, but that's not something that's clinically available to you. The gold standard is neuropsychological evaluation. So if you've been following me for some time, I hope that you know exactly what it is a neuropsychologist does. And if you don't, you better listen up, because we are clinical psychologists that have training and expertise in brain and behavior. And with the 3 primary tools that we use, we really are the experts in dementia. We absolutely love putting a complicated picture together and figuring out the accurate diagnosis and personalizing treatment recommendations. So our 3 tools are a very in-depth review of medical records, very comprehensive interviews with folks and their loved ones, and comprehensive cognitive testing, paper and pencil testing. You cannot diagnose dementia accurately without paper and pencil testing, because what we care about in dementia is function. The structure of the brain, what it looks like in pictures. Yes, this is important. But there are studies that have shown that 25% of people on an autopsy would meet criteria for Alzheimer's disease who showed no symptoms of it at all in everyday life. So we have a big split in how the brain may look versus what the brain can actually do. So let's talk about how to tease apart Lewy body from Parkinson's, because this is a big one. This is very, very difficult because there's a lot of overlap between these two, but we do have something called the 1-year rule. And the idea is that basically when motor symptoms begin more than a year before the dementia, we start to think about Parkinson's disease with dementia. When motor symptoms begin within the same year or after the cognitive changes, then we start to think more about Lewy body dementia. All people who have Parkinson's disease dementia are, of course, going to have motor symptoms, right? So what I mean by motor symptoms are tremor, stiffness in the muscles, rigidity, spasticity, these kind of a thing. but only 25 to 50% of people with dementia with Lewy body are going to have Parkinson's symptoms when they're diagnosed. Over time, 80 to 100% of people are going to develop these symptoms, but at the time of diagnosis, this is what we care about. The other thing, of course, is that 100% of people with Lewy body dementia have dementia. Only 25% of people with Parkinson's go on to develop dementia. Separating Lewy body from Alzheimer's is also tricky, but absolutely something a good neuropsychologist can do. And where we really look to here are the cognitive symptoms and the behavior symptoms. So in Alzheimer's disease, what we see a lot on the front end is trouble with new learning and short-term memory. This actually does not become that significant in Lewy body dementia until a little bit down the road. The first thing that you typically see in Lewy body are what we call executive dysfunction, which is trouble with complex planning and organization, but also things that involve visuospatial abilities, being able to park the car, parallel park. These are excellent real-world examples of the difficulties that people would have early on with Lewy body dementia. The other thing is that with Alzheimer's, you do have some fluctuating mental status, but it's typically around the sundowning time. So as some of you know who care about someone with Alzheimer's disease, between 4 and 6, depending on the time of year, agitation can occur. I want to go home. Where am I? Someone needs to come get me. We get a lot of anxiety about I'm not in the right place. I need to go somewhere. With Lewy body dementia, the fluctuating mental status is so much shorter. The intervals are so much shorter. It happens all throughout the day, and it's really, really noticeable to people who know these folks well. I also said there's a distinction in the so-called behavior symptoms. So remember, with dementia, it's never just cognitive. It's always cognitive, mood and behavior, and everyday functioning. Okay, so within mood and behavior, remember I was telling you about the visual hallucinations in dementia with Lewy body. Well, in Alzheimer's, it tends to be more delusion. So people coming into my house stealing things. Someone has come into my home and has stolen my jewelry. With Lewy body, it tends to be much more visual, and the hallucinations are typically not distressing to the person with Lewy body, and that is critical when we start to talk about treatment. I'm going to come back around to that. Now, of course, what did I say in the beginning is that part of why dementia with Lewy body is so poorly recognized is because it's very often in coexistence with another type of dementia. So many times people don't just have Lewy body, they have Alzheimer's and Lewy body. They have Parkinson's disease with dementia and Lewy body. Okay, there's a lot of commingling, especially as people get further and further into their dementia, that starts to happen. I wanted to just talk briefly about the genetics of Lewy body because I know a lot of you are listening who have a parent or a brother or sister or a grandparent who has this diagnosis. And yes, you are at a slightly increased risk for developing dementia as you get older, but not necessarily this specific type of dementia, okay? So anyone who has a first or second degree relative, which is, basically what we know of our family history, with a diagnosis of dementia is more at risk, but not necessarily like I just said. So if you have a mom with Lewy body dementia, doesn't mean you're going to get Lewy body. You are at a slightly increased risk. But remember, almost all late onset dementias are a combination of a gene and environment interaction. So the idea is that something that we do in our lifestyle turns on the gene, and this is what we don't know. A lot of these genes have been mapped out by all those really smart people who do genetics. But what we don't know, the missing piece, is what in the environment is turning on that gene and activating it. Now, we have some very good understanding about this, so cardiovascular disease, not enough socializing, not enough cognitive stimulation, eating poor food, all of these things. But what we don't know are specifics on how to advise people who have a family history, unfortunately. So let's talk a little bit about treatment, because there's two things that are critical here. The first one is what we need to think about with Lewy body is not necessarily medications to prescribe, it's medications to avoid, okay? And this gets important when we think about the visual hallucinations, because many times, although the person themselves may not be concerned or distressed, the minute they tell someone who doesn't understand Lewy body dementia that they are seeing little boys and girls running around their house, many times these people get brought to the emergency room because the listener is nervous, is scary. It sounds like a psychiatric problem to them. So many times people with Lewy body get brought to the emergency room. Emergency room doctors, as good as they are unfortunately not the best with and you know, that's a gross generalization, but my experience, and I think when you look at the research, are not necessarily that proficient in recognizing subtypes of dementia and helping to manage the symptoms. And what can often happen is that these people are labeled as having psychotic symptoms, and they are given antipsychotic medications. And the ones they're most likely to get are the cheapest ones, which are the oldest ones, which are the most damaging to people with Lewy body dementia. So there is something called neuroleptic malignant syndrome, NMS, and people with Lewy body who take these medications can have a dramatic worsening of their symptoms, a lot of muscle cramps, fever, way more confusion, and it really just throws them into a tailspin, and it does the exact opposite of what everybody wants to happen, which is to calm them and to comfort them. About 60% of people with Lewy body will have that reaction to those medications. So one of the things I want you to do is to make sure, if you are affected by this disease, you carry with you or your loved one in their wallet a card that says, I have been diagnosed with Lewy body dementia. Please do not give me the following medications. And I'm going to tell you a website at the end where you can do that. You can also get a medical bracelet that will say that very thing. But what I want you to know is that there actually are medications out there, really one, that helps a lot with the cognitive symptoms, but we often think of it as an Alzheimer's drug. So it's Aricept or donepezil. Now remember, I am a psychologist. I'm not a medical prescriber. I'm not a physician, but I do keep up on this research pretty closely, and I understand how the medications work. So the idea when this medication was developed is that it was going to increase a chemical in the brain called choline, which many researchers at the time Aricept was invented, they thought that was the primary deficit in Alzheimer's disease, was that choline went down, because choline is known to be associated with learning and memory. And remember, those are the two things that happen first in Alzheimer's. But unfortunately, that theory was disproven a couple years later. And so it is FDA approved for Alzheimer's disease. However, we actually know that a decline in choline has a lot to do with Lewy body dementia. So if you know of someone who has Lewy body, they really, really need to be considered for Aricept, or the generic name is donepezil, because many people, many patients tell me, oh my goodness, I really saw an improvement. I saw more of a stability in their mental status. I didn't see things going as up and down so much. There is a new drug on the horizon for Lewy body called nilotanserin, which has been evaluated in 5 phase 1 clinical trials and 2 phase 2s, which basically means we're getting closer to it actually being on the market. And what it is marketed for is treatment of those REM sleep disorder symptoms, so acting out their dreams, and the visual hallucinations. So we are getting eager to have that on the market, because so often a piece of care that is missing for patients with dementia is the mood and behavior disturbance. And I'm hoping that we're moving to more of a progressive treatment model in which dementia is always treated with the cognitive symptoms and the mood and behavior symptoms over here. For some reason, we've gotten really focused on memory, and we're not quite as focused on helping people with the anxiety and the agitation that can sometimes come along with dementia. Not always, but sometimes. So I have a rule of thumb for you about treating the psychotic symptoms that come along with Lewy body dementia, and it's very simple. Is the person distressed? If they are, do something about it. If they are not, you have to get comfortable with whatever it is they're seeing and reporting. So when someone is distressed, you really have 2 more decisions. The first one is you can do what we call non-pharmacological interventions, which are not medications, which are really creative and sensitive problem-solving techniques, being observant, thinking about what is a trigger for that person to have the hallucination. I was recently working with someone, a very talented care manager, and she was helping me understand that for one of her patients, anytime there was a newspaper in the environment, the patient thought that there were people that were reading her thoughts. For whatever reason, these messages got all messed up in her mind, and this was her trigger. So they just took newspapers out of the house, and she never ever had that psychotic symptom again. You always want that to be your first line of defense. However, that does not work for every patient, and there is a time and a place for psychiatric medications in the care of people with dementia, in my opinion. So you have to try to find a psychiatrist who understands geriatrics and dementia. And I know they're rare, but do yourself a favor, even if it's a one-time consultation, track that person down. Visual hallucinations are so important to treat if the person is distressed by them, because they're the #1 risk factor for early institutionalization in Lewy body dementia. And for many people and their families, they don't want their loved one to go into a facility. They want to keep them at home. So the research tells us if we can contain those symptoms, we can probably do a good job at letting people age in place. There is a real lack of research in the non-pharmacological interventions for Lewy body. There's actually a lot of research for these when it comes to Alzheimer's disease and Parkinson's. The very best study that I could find, which was actually a review study, came out just last year in 2017 from our esteemed colleagues in Sydney, Australia. And in England, they did a little collaboration there, and it was in the Journal of Psychological Medicine. And basically what they concluded is there's very little for Lewy body, so the best we can advise people is let's look to see what's worked in other subtypes of dementia that have similar symptoms, and let's give people those recommendations. So I have gone through those for you for this talk today, and this is how we're going to conclude in the what can I do about this part. Okay, so you know how there are the Parkinson's symptoms, the motor disorder symptoms. Well, we absolutely know that moderate to high intensity exercise is unbelievably effective at not only helping the person learn to compensate for troubles with balance and gait, basically teaching people how to fall properly so they don't get hurt. It has some unbelievably impressive results in terms of actual brain chemistry and physiology. It really encourages the production of growth hormone in the brain, which helps all those little dendrites, all the little connectors and communicators thrive, and this is how people have better mental clarity and better physical functioning. So in my area in North Carolina, we have an absolutely amazing local neurophysical therapist. So I want you to look up in your area if you have someone who does that specialty. In my area, her name is Dr. Laura Beck, and she has a program called Rock Steady Boxing, and she also works at a place called Max Motion locally, and she is truly outstanding. You need to have a physical therapist, if you can find one, that gets it, that understands the brain, that is not just coming at physical therapy strictly from a body up perspective. We want to come from a brain down perspective. The next thing that we know works just for general care, but specifically those psychiatric symptoms, is interventions for the caregiver. The truth is there's not much that we can do to help that individual be more comforted. So we try all the things I talked about before, environmental changes, finding a psychiatrist, but what the research says is if we can actually comfort and soothe the caregiver, the patient themselves tends to do better, because our reaction is very catchy to people with dementia. When cognition fails, we become more intuitive and we sense people's mood and their reaction and their emotions. So imagine if you're a caregiver and you don't know that a common symptom in Lewy body dementia is a visual hallucination, and your mom comes up to you and she says, "There's a snake in my room. Oh my God, there's a snake in my room." First of all, you're going to be petrified and want to go get that snake. But if you realize there is no snake in there, you might start to think, oh my gosh, she is terrified and she's totally losing it. She's hallucinating. And your reaction is then going to affect her. So we have to get to the caregivers and give them the best support that we possibly can. The next recommendation is for those autonomic symptoms. So this is the trouble with hypotension, your blood pressure not being that regulated, trouble with getting up too quickly and feeling a little fuzzy, trouble with balance. So what the research says is that increasing the salt in the diet is helpful. Using compression stockings to make sure that the fluid distribution in the body stays steady. We also know that elevating the head during sleep can actually help minimize what they call supine hypertension, and this can be very, very helpful. So someone doesn't go from flat to up when they get up. They simply go from kind of propped up to up, okay? The next one is that one of the autonomic symptoms is constipation, because what it really is everything slowing down. So this happens in every system in the body. So increasing fluid intake and fiber can be very helpful to that. I want to end by telling you a little bit more about some of those barriers towards getting this dementia diagnosed properly. And there was a poster that came out. Research studies are either in journal articles or in posters at conferences. A poster that came out just this year that interviewed doctors who would be most likely to see Lewy body patients, and they asked them about how open would you be to using a toolkit that would help you diagnose this condition more. And they actually concluded in this poster that we're not even ready for a toolkit yet because doctors don't believe in the value, I almost can't even say this, they don't believe in the value of diagnosing dementia accurately. Now again, gross generalization, not every doctor for sure. I have some of the most amazing primary care physicians that I work with in my area, but in this study, what they said was, A, this doesn't matter to my practice because I rarely see these people, which is BS. It's just that you don't know you're seeing them. The next one is there's such little point in diagnosing Lewy body because what's the difference? We're not going to be able to do anything to stop it anyway. BS, because we know that the Aricept is going to help. The other one is I don't want to depress the person. Why say that word dementia when I'm just going to ruin their day? Pretty bad, pretty bad. I mean, my thought is, how dare they? You and your family have a right to know exactly what your diagnosis is. And if your doctor is not willing to help you pursue an accurate diagnosis, you have to become the advocate for yourself. The key thing about Lewy body dementia, like all the subtypes of dementia, is early diagnosis. The earlier you get that person to me or a neuropsychologist, the earlier I can help you, the earlier I can put your concerns to rest about what's going on, because I'm going to be able to make sense of it with a diagnosis and tell you what to expect. Where are we going to go in the future? The Lewy Body Association on the internet is an excellent, trusted source of information. I encourage you to go on there. They have the wallet cards that I was telling you about before. If you need help in finding a local board-certified neuropsychologist, you go on Google and you put in find board-certified neuropsychologist. It will walk you through the process. If you have a hard time, you send me and my team here a message and we will find the closest person to you and send you their contact information. If this talk tonight was helpful to you, if it feels like, yes, I want more of this high quality information, please like and share our page. The more people that know about what we're doing here, the more I can do it. We're really trying to build a movement here that's based on education and empowerment, and I could not do it without you. So thank you so much for listening, and I will see you guys next week. Bye-bye.